introductions in the chat. That's terrific. Thank you. Okay. All right, Mana, I think we should go ahead and get started because there's a lot of folks here and we have a full agenda that we need to, that we certainly need to get through. Sorry about that. Meant to be on this slide. So let's go ahead and start the recording. Since today is a recorded meeting, so that's why everybody's on mute right now. And so you can simply hold the space bar down if you need to unmute yourself, or actually just hit your microphone and that will unmute you as well. But let me welcome everybody to the Peer Recovery Support Services Community of Practice. Today's interactive presentation and group discussion is focused on harm reduction in recovery services. My name is Mary Ellen Shannon, and I'm the Director of Technical Assistance Center, and I now also be your moderator today. So today's learning event is the result of a collaborative planning process involving members from Greater Tilton Area Family Resource Center, Revive Recovery Resource Center, Harbor Care, and the Bureau of Drug and Alcohol Services, as well as Growth Partners. Growth Partners is the Bureau's new technical assistance contractor, and we operate the Technical Assistance Center. So it's really great to meet all of you and see you. We are, as I mentioned, we are recording today's meeting, so we ask everybody to please mute your microphone when you're not speaking so we can have a clear recording. If you are having any internet issues, you can try turning off your video camera, or you can also join by phone. Those numbers were provided with the link. And also, if you're having any trouble hearing, you can expand the audio icon and open the audio settings, and that's where you can select a different speaker from the menu, or you can adjust the volume. And if you're still having any issues, you can go ahead and send a chat to our host, Mana Rose, and she'll see what she can do to help you out. So we want everybody to be able to participate fully today. So by the end of this meeting, we plan for everybody, my slides are jumping around here, that you will be able to define and identify harm reduction strategies, particularly those used in recovery services. And before we jump into our agenda and the full meeting, I want to go ahead and get to know all of you a little bit. So we're going to go ahead and launch a poll. There's just 3 quick questions that ask a little bit about who you are and your knowledge and experience with harm reduction strategies and recovery services. So appreciate your time and just going ahead and answering those questions so we can get to know you. So today's agenda, this is how we'll spend the next hour and 55 minutes or so together. You can see it's pretty full, starting with the poll you're doing now. Well, it'll be followed by an overview of harm reduction when Carrie Nolte joins us. And you'll also be hearing from 4 panel members who will share their experiences and expertise in using harm reduction strategies in their recovery work. We'll also have a time in small group discussion on the topic, and then we'll have a report out from each group so we can hear the discussion, what the discussion entailed in each one of the groups. And that will be followed up with a large group Q&A for the panel members, as well as a wrap-up and last resources and an evaluation that we will have a link to toward the end of the meeting. So just checking in to see if Carrie Nolte has joined us yet.
Not at this time.
Not at this time. Okay. All right. I just want to mention one thing about the evaluation. We will have a link, and those that complete the evaluation, we've been told will actually receive a certificate that you can use to submit to the licensing board to apply for CEUs. We weren't able to obtain CEU credits for this event in advance, but we are able to issue a certificate to those that complete the evaluation. So that's added incentive to stay around to the end and complete that evaluation for us. Thanks. All right. So I think we will go ahead and start out with our panel members and have them share. If each one of you could share some information about just harm reduction strategies and your experience with that, especially as it relates to recovery services. We'll start out with Joe Hannon. I'm sorry, yep, I got that right, Joe Hannon. Joe is a former member of the New Hampshire House of Representatives, and he is a state and community volunteer and a person in long-term recovery. Then we'll hear from John Burns, who is the director of SOS Recovery Community Organization and also a person in long-term recovery, followed by Ryan Fowler, who is a harm reduction coordinator for the HIV/HCV Resource Center, is a certified recovery support worker and person in sustained recovery. And that will be followed up with Jessica Parnell, who is the executive director of Revive Recovery Resource Center, recovery and harm reduction. She is a recovery and harm reduction trainer, pardon me, and recovery community center supervisor. So special thanks and warm welcome to each one of the panelists. And Joe, I'm going to turn things over to you.
Great. Hi. Well, thank you. And hello, everybody. I know Carrie wasn't feeling well, and I apologize. She was really not feeling well last night, and gave me a heads up that she wasn't well, but I didn't know she wouldn't be here. So I could quickly do a real brief intro to harm reduction if you'd like. If I could share slides. I do have some slides from an old presentation that I updated the date on, so it looks like I just did it for you guys. So if I could share a screen, that might help. I could do a real quick, couple minute introduction. If she gets here, she can always do more, but it might help
Perfect.
to do. Might help.
Thanks, Joe. Appreciate that.
Yeah, no problem.
You should have control now.
Oh, great. All right.
We're in your hands.
Let's see. Do you see a screen?
We do.
All right. Awesome. Does it say something interesting? Good. All right.
It does.
All right. Here we go. So real quick about myself, like you heard, I'm a former legislator. I helped write the syringe exchange legislation and the Narcan, the naloxone legislation. I also am the policy director for the New Hampshire Harm Reduction Coalition, the chair of SOS Recovery Community Organizations Advisory Board, and a person in long-term recovery. So enough about me. I want to get into a few basic principles of harm reduction. I'm sure most of you know a lot of this stuff. I just want to breeze through them real quick. So in case anyone's not sure, what is harm reduction? It's basically a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. It's also a movement for social justice, built on the belief in and respect for the rights of people who use drugs. What are the goals of it? It's to improve the health and well-being of individuals, their partners, families, associates, and communities. And it also, we try to highlight the roles of discrimination due to poverty, racism, classism, sexism, social isolation, trauma, and other inequalities in drug-related harm. And also, we want to push the roles of dignity, respect, and empowerment in reducing harm to those individuals. Another big part of harm reduction is it prevents disease. Over 35,000 people are newly infected with HIV every year. There's over 1 million people living with HIV. 30,000 people are infected with hepatitis C every year, and there's 3.5 million plus people living with hepatitis C. And there has been an explosion of soft tissue infections and endocarditis because of IV drug use. There's a lot of evidence and supports that syringe service programs can do a lot to reduce these harms. There's a 5 times more likelihood that people are going to be referred and enter into substance use disorder treatment. It reduces needle stick injuries, especially amongst first responders. Police officers, their second biggest fear after being shot in the line of duty is being stuck with a syringe. So it definitely does a lot to decrease the risks of that. And even if someone is stuck with a syringe in work or the line of duty, if there are syringe programs around, there's a lot less likelihood of those individuals being infected with a contaminated syringe. It reduces overdose deaths. It's been proven that the use of naloxone, we all know, can save lives. But it also is a way that we can connect people to other services, by having those discussions about overdose prevention and treatment and recovery. It also saves money. Harm reduction saves money, and I'd like to say that harm reduction is not just syringe exchange. Harm reduction, we are all harm reductionists, whether we know it or not. Raise your hand if you wear a seatbelt when you drive. Wow, none of you wear a seatbelt. Okay, I can see you. You can't see me. But I got asked that once, and the whole room raised their hand. But I showed up on a motorcycle, so I felt like the real jerk in the room until I'd explained myself. But anyway, harm reduction is wearing a seatbelt, wearing a helmet when you ride a bicycle. It can be eating bacon 3 times a week instead of 7. I mean, that's a form of harm reduction. We don't think about these things in terms of what we're talking about now, but that's really what it is. We know that people are going to do certain behaviors, but the goal of harm reduction is there a way to reduce these behaviors to make better choices for health and longevity and lifestyle. I can go into a lot of the endorsement. Sorry, I'll skip some of these slides because this was not exactly for this, but maybe we are done this part. So, okay, here we go. One thing, like I was saying, syringe access and for syringe services are a major access point for engagement of individuals to other services. So, there's many people that we know that are using IV drugs that are afraid to go to hospitals or afraid to walk into a recovery center initially. And sometimes their first encounter is with a syringe service program or a harm reduction group. They might have been given naloxone by someone, but the chances are their first encounter with someone who's trying to engage them in a non-judgmental way is in a harm reduction group. We see people all the time that are infected with abscesses or cellulitis, and they're actually afraid to go to the hospital. This is not unusual. It happens very frequently. I had a lot of experience doing wound care as a doctor, and I can tell you that when I see something, I know when it needs to go to the hospital. I tell people this, and oftentimes they still won't go because of their fear of going to this institution or another. And the reasons, they may not seem valid to the doctor when you tell them about it. Like, hey, they're afraid to come to your hospital, and they look at you like you're crazy. But the fact is, there is different treatment by people who either look different, or if they seem like they have a substance use disorder or they're homeless. If I walked in, clean, nice haircut, nice suit, and I walked in, I'm probably going to get better treatment than someone who walks in, covered with, tattoos and dirty and the stereotypical, what the people in healthcare often think is someone who's using substances. The treatment level, even if they don't say it's the same, you definitely have a different attitude towards people. So harm reduction is also about educating and empowering not just the individuals, but the people who help those individuals. Okay, the rest of it's just about syringe service program. So I guess I'm done with that part. I'll let Kerry do the rest if there's more to come on. Hold on 1 second, I'm trying to get out of the screen. Stop share. Someone stop me sharing. Stop share, there we go, sorry.
Thank you, Joe. That's
All right.
helpful.
So now I can do real quick my little 5 minutes then. So, like I said, I'm a person in long-term recovery. I came around at a ripe old age of 19. So this is back in a time where basically the public enemy number one was, people using drugs. It was a very hard time to be coming around in recovery. Probably not as hard as it was even 20 years before that, but it was a time where even in the recovery world, there was either You're doing drugs or you're not doing drugs. There was no in between. You couldn't walk into an AA meeting or any other 12-step group and say, oh yeah, hi, I'm an alcoholic, but I smoke pot. They would just, actually, they'd be angry. It wouldn't even be a discussion. There'd be nothing going on. Now, I didn't do that, but I know a lot of people that were actually afraid, and there's still people afraid to take medications. People that are in some forms of recovery are actually fearful to admit that they take medicine for depression, whether it's Paxil, whether it's attention deficit medication. They feel that there's a stigma associated with that in certain recovery circles. Now, I'm not trying to, badmouth any types of recovery. Different forms of recovery work for different types of people. Traditional 12-step recovery is actually what got me to where I am today, if that means anything to people watching. So, a big part of it is, one of my goals is to try to break down some of the barriers to what is traditional recovery, and harm reduction is a big part of that. So if someone's saying, frequently in the syringe program, I might see someone who's doing fentanyl 8 times a day. Well, I don't tell that person, hey, you need to go into an abstinence-based recovery program. You need to go to rehab today. That might not be the conversation that gets someone to where they want to be. The first thing I can do is accept them and love them for who they are, not say, hey, what are you doing? Why are you doing 10 bags a day or this? That almost ends the conversation for most people, especially in active disease. So, what do we do? Part of harm reduction is just saying, hey, how are you doing today? Ask them things. Just talk to them to start with. And they'll tell you what's going on after a while. And it takes some time before people get to trust you, especially in active disease. You might not know it from this picture, but I had pretty short hair. I was very clean cut looking, and everyone thought I was a cop. So I actually had to get a t-shirt that said, not a cop. I don't have to do that anymore. They kind of leave me alone, but it takes a while to build that trust. And then even if you look, however you look, after time, you can build relationships with people. And then if you love them and you don't judge them, they'll start to tell you things, obviously. And that's not just recovery or substance use, it's anything. Being non-judgmental is the one bridge to getting people to trust. And trust is a big part of harm reduction. No one's going to listen or trust things you have to say until they do. But another thing is, I don't just tell people what they want, what I want them to hear. I try to listen for what they need to hear or what they're asking for. So if I say, what do you need today? They'll say, oh, I need new syringes. I need alcohol swabs. I need a place to stay. I'm not going to go off onto a tangent. Well, hey, here's a shower, or here's a phone number for a long-term treatment program. That's not the first thing I'm going to enter with in that discussion. I'm going to try to meet their needs and meet them where they are, just like we do in a normal recovery peer recovery setting. So once those needs are met, it may seem like it's enabling, and yeah, it is enabling. I'm enabling someone to not get sick, not get disease, and not die. I give them Narcan, clean syringes. That's harm reduction. And in recovery, it's the same way. What do we want to do? We don't want that person to die. We don't want them to get worse. And if that means that we have to take them along a stepwise approach when they're ready, that's what we have to do. So reducing the harm is really about finding out what their needs are and trying to find out how they can come up with their own ideas of how to better themselves and where they are. So that's basically my brief spiel. I'd love to answer questions and talk to everyone else and hear some of your experiences, but I know we have a few other presenters they're just itching to get on. And I really appreciate everyone's time, and let me know if there's anything I can do for any of you. Thank you. Shawl claps, thanks.
Claps.
Yay!
Why not? Thank you. Thank you.
Nice job, Joe, and we appreciate you jumping in there on the fly and sharing some overview about harm reduction as well. And I know I'm going to throw things a little bit out of order here just to keep our panel members on their toes, if that's okay. I understand that Ryan has maybe some PowerPoint queued up and some information he'd like to share as well. So we'll move to Ryan, Harm Reduction Coordinator for the HIV/HCV Resource Center next. Ryan, does that sound good to you?
Yeah, I had just let Polly know that in Carrie's absence, I could more or less do what Joe just did. I have some other content I'm happy to throw up, or I can extend my 5-minute panel presentation, whatever makes sense. I don't know, with Carrie not being here, it's hard to, so just
Sure,
let me know what's
absolutely.
best.
Sure, absolutely. We'd love for you to go ahead and take a little bit more of your 5 minutes. If you've got some additional content you'd like to share that relates to examples of what harm reduction looks like in recovery services. So, so if you've got that queued up and ready to go for it.
Cool. All right. All right. Can y'all see that?
We do,
And
yes.
y'all can hear me?
Yep.
Cool. So my name is Ryan, and I am a person in recovery from a substance use disorder, and I'm also a person who uses drugs. I practice moderation management, and I have recently celebrated 6 years of continuous recovery. My experience with recovery is that, you know, I'm a former injection drug user. I'm somebody who's alive because of naloxone 3 different times. First responders came and reversed my overdose because of naloxone. But really, when I became an injection drug user at 20 years old, I was taught how to inject using my sexual partner's old syringes. Like when she was really done with them, I got them 3rd, 4th, 5th, 6th time around. And that was how I was taught to inject. And then I went about my way and endured some infections and some overdoses. And I met 2 people, one from Vermont and one from Massachusetts, who illegally at the time provided me with syringes and an education about viral hepatitis, HIV, using sterile works, not sharing them, not using alone, and harm reduction. And I didn't know what harm reduction was at that point. I didn't have language for that, but I really appreciated the free syringes. And really, people throughout my life kind of came and insulated me from chaotic drug use. You know, I basically used and sold drugs chaotically for about 10 years. And the last 5 years of that, I was an injection drug user, injecting a lot of cocaine and heroin. And I would attempt rehab. I would get in trouble and go to detox and rehab. I would go to 12-step meetings. And what would basically go down was I would be abstinent for a very short period of time, a month at the most. I would start smoking pot. I really like cannabis. I use it every day. And people in these 12-step fellowships would tell me, like, what's the point? If you're just going to smoke pot every day, you might as well shoot heroin. It's like literally what I was told, is that, you know, if you're just going to do this sometimes, you're going to end up relapsing. There's this phenomena of craving. This thing is going to happen. And I manifested that on myself time and time again, where, you know, well-intended people were just telling me that, you know, as a drug user, I shouldn't use drugs. And eventually I hit a bottom. I was saved by naloxone for the 3rd time. And I was shown dignity and respect. And, you know, actually at first it was 2 cops who arrested me, showed me a lot of dignity and respect, and asked me questions that really motivated me for change. I was just beat up, and I had a lot of social privilege, and I was told that's recovery capital, but I really had, you know, a family that could house and feed me. I had access to, at the time, state-funded treatment. And so I spent Christmas and New Year's of 2014 in my 4th 28-day program, Phoenix House in Dublin. I really made the most of it, but I was really motivated by myself. I wasn't motivated by people telling me to not. I really wanted to know more about my issues with trauma from my childhood and as an adult, and why I couldn't stop injecting cocaine and using heroin to sleep. And so I learned a different approach to addiction recovery that time around with a really great counselor. And I learned that this is a brain disorder. It's preventable, treatable, and can go into remission. And I don't need to tell myself I have a disease. Like, I never liked saying like I have a disease. Like, I don't think of myself as diseased. Society thinks of me as diseased, but because of harm reduction, I don't have Hep C, I don't have HIV, I have a clean bill of health because of harm reduction. So the idea that I have this eternal disease that's never going to go away from me just didn't make sense. But I learned about dopamine and the role of neuroplasticity and the role of the environment. And it turns out that there is a geographic here. An environment does play a big role in addiction recovery. And so I learned about myself. I learned about my disorder. I learned about trauma, and I left rehab and did 9 months of mental health counseling, found the 12 steps, found a sponsor, found God, found church, found Jesus, had this really kind of picturesque recovery experience that first couple years where when I entered recovery centers weren't a thing. There was no addiction crisis line. I just had family who was in AA and helped me get into rehab. So when one of the first centers, Safe Harbor, was opening up in Portsmouth, I was asked to take the Recovery Coach Academy and learn about different pathways to recovery. And that's when I met, people like John Burns, who had other pathways of recovery that weren't my like big book or die approach. Like, to me, I was a hopeless disease junkie, and the only thing that worked was the 12 steps. And so that had to work for you. It was big book or die all the way around. But I also believed in drug policy reform and criminal justice reform. And I believed in a prescription model for people who are going to use drugs forever. Like, I believed in these kind of radical harm reduction ideas, but I didn't call it harm reduction. I knew safer use strategies, but I didn't call it harm reduction. And when I learned about harm reduction in the Recovery Coach Academy, it gave me a sense of dissonance. Like, I didn't think it was true, and I thought it was kind of bullshit that I was going to coach people on how to use safely. I was out here to carry a message and deliver the 12 steps to people. That's all I really wanted to do. But, once I understood harm reduction to be about a little bit more than that, and as Joe pointed out, harm reduction being kind of concept and strategy that we use all the time, I started to realize that any human behavior serves a purpose. And as far as drug use, the people that I love are using drugs for a reason. And it's not my place to tell them why they shouldn't. It's my place to love them, mitigate suffering until they find what makes sense for them. And the truth is, many people I know will use drugs forever, and that's fine. But it's about love and treating people with dignity and respect and compassion and empowering them so that they find their own autonomy and their agency and they make better choices. And what I've seen throughout the years of finding harm reduction and entering into a professional space of addiction treatment and recovery that was full of hypocrisy, all pathways of recovery that are abstinent, and maybe MAT at these programs. There's a kind of this dichotomy that I'd find throughout treatment and addiction and recovery, working for various state-funded systems. And then harm reduction is the truth. Like, I don't really need you to believe in harm reduction. You don't need to believe in the truth for the truth to be what it is. That's why people gravitate towards harm reduction, because it's speaking truth to power, and it's acknowledging the systemic injustice and the inequities in our society, living under prohibition and the war on drugs and punitive measures for using drugs. And we define use disorders as continuing to use drugs despite negative consequences, but throughout systems, we only offer negative consequences. And so when I learned about harm reduction and the fact that I can take these tools of harm reduction and go to people that I love and support them and love them and give them things like naloxone or sterile equipment, everything I was told about the people from my past and 12-step fellowships went out the window, because I was told they were going to kill me. They were bad for me. They weren't my friends. They were my associates. But I come from a very loyal crime family who would die for me, and I would die for them. And so the idea that those people weren't my friends really didn't sit well with me. And so I found harm reduction, and I would go back to people from my past and love on them and, show them non-coercive support, showing them love and compassion, and seeing what they want to work on and allowing them to define their own goals. And this is the natural part of recovery that happens with harm reduction. And so for the past year, I've been running the Claremont Exchange, a small syringe services program in Sullivan County and Grafton County. I use a peer-to-peer model of secondary distribution of supplies where I go and meet one person, I train them, I educate them, I give them the information they need, and they go back to an existing system of distribution, a drug market, a trap house, whatever you want to call it, and they use existing systems to dispense supplies, information, and education. And I have participants who have set up supervised consumption sites in their apartment. I have participants who have time and time again gone from rough around the edges participant to volunteer to I'm not injecting, but I want to give these to my friends to I never see them again. They're at the RCO. They went to detox. They're on MAT. And it's been hard switching from a traditional CRSW role to a harm reduction support role because it's less hand holding. It's less paperwork. It's more just genuine, authentic connections. And when I become part of people's past, that's a good thing. But it took me a while to work through the people I'm supporting not calling me anymore, but I'm the needle guy. And I love that. I consider what I do a privilege and an honor to meet people where they're at, but not leave them there. To meet them where they're at and provide services based on their conditions without evangelizing them or treading on their, autonomy and agency. And, harm reduction just makes a lot of sense. And I've seen so many people leave the Claremont Exchange to go find recovery. I've seen it in my personal life with family and friends. And, I think that we kind of overcomplicate harm reduction being its own thing. Abstinence is harm reduction. If we think about drugs are about a relationship to drugs, and avoidance of drugs is a relationship to drugs. And so abstinence is harm reduction. For some people, harm reduction means they no longer take drugs. Abstinence is on the spectrum of strategies of harm reduction. And so it's really just about taking these principles of understanding people and seeking to understand people and allowing them to enter recovery, because people are on a natural pathway towards recovery. They just need love and support and a step in the right direction. And it's really just, it's really been an honor to do this work. I don't know how long that was, but I'm happy to open it up to the next people who want to talk about this stuff. Thanks for listening.
Thank you, Ryan. That was actually perfect. I see everybody's applauding. Yes, that was a perfect amount of time, and we really appreciate you sharing your story. It's a great example of harm reduction and how it works. So I'm going to transition now over to John Burns, panelist, and I'm going to open it up. John and Jessica, you guys both have about 10 minutes to share what you have. So John.
Thank you. Good morning, everyone. My name is John Burns. I am with SOS Recovery Community Organization. We have centers in Rochester, Dover, and Hampton. I'm also a big advocate of harm reduction. I think as it relates to recovery, which I think is important, one of the common themes or common taglines we hear around recovery is meeting people where they're at. But too often we see within the recovery community that means we meet people where they're at so long as they're headed towards abstinence. And I think that's an important distinction, is that if you're going to carry the tagline, you need to walk the walk with that. And so that's kind of a culture that we've tried to build here, is that the abstinence is great and we fully support that, because that's also a pathway, but it's not the end all be all. And for a lot of people, abstinence isn't part of their pathway to or for recovery. And harm reduction is a legitimate pathway with recovery, and it's one that we need to embrace. So for us as an organization, there's a 3-day harm reduction or recovery coaching pathway. So we hosted that a couple of years ago. We have people who train to be trainers in that here with SOS. I thought that was a critical thing to bring in, that Dean Lemire and Jim Wolfing created. And it's a powerful training that we hope to do some more in the future. Some of the efforts that we've also done, I think, and the big one is again, building that culture. So that's not only true for people who walk through the doors of SOS, that's true for our volunteers, and that's true for our staff. If we have staff that their pathway is not strict abstinence, then they're welcomed into our organization as well. So abstinence has to be, so while we're open, and for our staff, you can't be under the influence while you're providing recovery supports, but that doesn't mean that what they do outside of work needs to be a strict abstinence pathway. So I think that's important for us to recognize when we look at harm reduction and how we bring together the harm reduction and the recovery communities, because one of the things I noticed in my travels is I've been to several of the national and international harm reduction conferences, and you have a ton of people in recovery attending them. And then you have a ton of people who are not, but there's almost like this rift that I recognize where people in harm reduction were very averse to the recovery community. And likewise, I've seen that in the recovery community being very averse to harm reduction. And it doesn't make sense because I think the goals are the same, and that is to help people get well and reduce harms. And I think bringing that together is important. So some of the stuff we've also done here at the beginning of the COVID pandemic, we are a program of a federally qualified health center with Greater Seacoast Community Health. We saw that at the start of the COVID pandemic, a lot of medically assisted recovery, medically assisted treatment programs were shutting down to new patients, and it was hard to access both methadone and buprenorphine programs. So we launched in conjunction with Goodwin Community Health and Families First, Greater Seacoast Community Health, we launched a mobile medically assisted recovery program. And literally we took a van that we had donated to SOS that we use, and we took it to a parking lot in downtown Dover, and we propped up some 10 by 10 canopy tents, and we brought recovery support specialists to do peer work there and do the intakes. We brought a provider who was brought in. We had portable Wi-Fi, and they did telehealth sessions with individuals that came into the tents. And we put privacy screens around the tents, and we had a registered nurse on site, and we were able to get people their inductions for medically assisted recovery. And it was a great partnership with Hand Up Health Services, which is part of the New Hampshire Harm Reduction Coalition, because honestly, about 75% of those who came into it were being referred from the syringe service program from Hand Up into this. And, you know, and we looked at a lot of the data around the people that did that. We did it for about 6 to 8 weeks. And one of the most powerful things about it was seeing that a lot of those individuals, like, it wasn't just they were coming and getting their Suboxone and they were done. They stuck with the program, and they were able to, you know, it became a recovery pathway for them to have that service available. And I can tell you that 90% of the people that walked through that door were not what we would traditionally see in brick and mortar methadone or buprenorphine Suboxone type programs. They weren't the people that would have probably walked into Goodwin Community Health otherwise. They were people who were often not stably housed and were averse to that brick and mortar, had a lot of social anxiety around that, but were comfortable coming in to do that. So that was one of the efforts we did. And then we also provide naloxone. So we're a distribution site for the state, like most of the recovery community orgs. But we have taken that a step further, and we've partnered with the local methadone clinic. So they have 2 clinics, one in Somersworth and one in Newington. And outside of COVID, it's backed off a little bit now because of COVID and safety issues. But typically we are there once a month, and we do both a combination of outreach around our services, as well as provide naloxone to their patients that are coming in and out of the methadone clinic. And on average, we give out anywhere from 125 to 150 naloxone kits a month when we're doing that. So it's not a small, we're there for about 4 to 6 hours, and we are training naloxone and hyperwarp to get people their kits. And we have gotten so many anecdotal stories from their patients of reversals as a result of that they weren't comfortable calling first responders because they're afraid of arrest, despite the laws that you would think the Good Samaritan laws would protect them. But unfortunately, with prosecution of people for death resulting, a lot of the people who are using drugs right now are not comfortable calling 911 regardless. So we've gotten a lot of anecdotal stories around overdose reversals where those aren't reflected in statistics because they're not calling 911, unfortunately. I wish they would, but I also understand, you know, and that's part of this process, is understanding some of those nuances with people who use drugs and being able to work with them and truly meet them where they're at with it and not judge them based on what they do or don't do, because our goal is just to be there for them and support them. And it's not unusual for us to have people come into our recovery centers who may be under the influence, and we have to balance that with protecting those who do practice abstinence and not putting their recovery at risk. So we can't be a drop-in center, but we can provide a safe space for somebody who might need it right now for a little while. And like, we're not going to let them nod off on the couch for 4 hours, but we will let them come in and grab some coffee and have a conversation with them and let them spend a little time and warm up in the cold. And then, and those are the individuals down the road. It's not unusual for them to come through our doors and be like, you were the only ones that weren't telling me I needed to go to treatment. And I want to go to treatment, or I want to get help now. But they feel safe because of the fact that we've kind of built that into our culture. So with that, I will kind of share the time. But those are some of the efforts we've done as a recovery community organization. And I think it's important that as a recovery community, that those of us involved in recovery community organizations are working closely with harm reduction and syringe service programs to build these efforts so that there is a better bridge between the two communities, because they really should be one community.
Terrific. Thank you, John. Applause, applause. I see everybody. Thank you for sharing. And Jessica, we'll turn things over to you. Let me just remind folks that if you do have comments or questions for our panel members as they're talking, and you're thinking about those questions now, please go ahead and put them into the chat. You can chat them out to everyone and we will get to them. We'll probably have some time at the end of our meeting to get to those questions for you. So Jessica.
Hi, everyone. Can everyone hear me? All right, can give me a thumbs up if you can hear me. Awesome. Thank you. So my name's Jessica Purnell, and I am a woman in long-term recovery. I'm also here today to represent Revive Recovery Center. We currently have locations in both Nashua and Derry, New Hampshire. I first became acquainted with syringe service programs in active use. I was a participant through secondary exchange of the York Harm Reduction Project in York, Pennsylvania. It's where I first began engaging in my own recovery process. Had some slips while I was down there, and some people that I was acquaintanced with used comprehensive harm reduction program down in York. So that's when I first kind of caught wind of it. All I knew at the time was that it was going to help me, get what I needed to get and use the supplies that I needed. And I kind of wish I had been more engaged in the project itself at the time. Fast forward to 2017, which is the end of 2017 is when I first started working at Revive Recovery Center. I started off as the state's first publicly funded recovery coaching position. I was called a community recovery coach, and my role with that was to kind of keep an eye on Nashua's Safe Station program and support some of the folks accessing that program while they were here in Nashua. And so when I first started at Revive, the program was run much differently than it is now. I myself was, my schedule was a lot lighter than it is today and could actively engage in direct service on a regular basis. We didn't, decide to use a bricks and mortar location, being that, we can't conduct syringe service within 1,000 feet of a drug-free school zone. So many of downtown Nashua, the areas are off limits. So we would provide, the services by delivery on demand. And it, got to a point where it was much harder to manage, and we've kind of, in more recent times recruited more volunteers and focused more on specific times and locations, which has turned out to work out pretty well. John, Joe, Ryan, and myself, I think, are here today to kind of talk about what it means to be someone in recovery and also, you know, promote a harm reduction pathway. I know a couple of the other presenters have alluded to a sense of like silos amongst, you know, the harm reduction community and then the recovery community. And I can, you know, attest to, you know, having that strong 12-step foundation where I was taught that, you know, this is dangerous. I've been accused by people who I admire in the recovery community of putting people's lives in jeopardy. And, you know, that's the kind of a conversation that we're all here to open up and really, you know, be able to make you feel as if you can have this conversation out in your community and help, you know, break down those silos because we need, I mean, both of the silos to be in communication if we really want this to work effectively. So SANA, I know I've kind of thrown it out there quite a bit, but it's the Syringe Service Alliance of the Nashua area. As I mentioned, we went live in February of 2018. It's a partnership between the Southern New Hampshire HIV/AIDS Task Force, which is now known as Harbor Care, Revive Recovery Center, the city's Division of Public Health and Community Services. And those were the founding organizations that were a part of it. And since we have added more partners, such as the Doorway, we work pretty collaboratively with our Doorway here in Nashua, and it's, you know, really begun to work out really well for us, as well as UMass Lowell and the New Hampshire Harm Reduction Coalition. We, you know, certainly wouldn't be here if it wasn't for all of those parties and many of the people that are on the panel with us today. And so, you know, I look forward to the breakout rooms and, you know, opening up some more discussion about like what it means to be someone in recovery and also, you know, fully embrace a harm reduction pathway as it is, you know, the same. So thank you.
Terrific. Yes, hand claps. Thank you, Jessica. Appreciate that. Thank you all panelists for sharing really, really good information. At this point, we're ready to enter into our breakout groups. And so let me just see if I can switch my slides here. Pardon me. Okay. So facilitators and co-facilitators, you all know who you are. We've talked with you already about this, so this is your time to get ready. We have each group that we break you into will have a co-facilitator and facilitator. Each group has about 20 minutes to discuss 3 questions. I'll show those in a minute. And then you'll return to the large group where we will have a report out. So as soon as you get into your groups, if you can decide on who's going to do that report out for you, that would be terrific. We've actually asked facilitators to be ready to take on that role of reporting out if there's no other volunteers. So the facilitator will engage members in the discussion. Co-facilitators, we ask that you will share your screen with the discussion questions. That's a slide. Also take notes. If you've got the note-taking template, that would be terrific if you could use that. If not, don't worry about it. We'll collect notes from you after the meeting. And participants, we ask all of you to really actively participate. Take advantage of this time that you have to explore these different viewpoints. We understand that everybody is coming into this meeting with a very different view and very different experiences as it relates to harm reduction and recovery services. So we want you to see these groups as a safe place to explore those various perspectives. And we ask that everybody in the group respect those different perspectives. And of course, if anybody has any issues when you're in group, any technical problems, any kind of glitches that occur, you can press the Ask for Help button, and our host, Mana Rose, will enter into your room virtually and be able to assist folks. So here are the questions that we want folks to answer in group. We want folks to be able to talk about their experience with harm reduction strategies. We want you to explore the value of harm reduction strategies in recovery. And then we also want you to discuss the challenges. What aspects of harm reduction do you see most challenging, or do you foresee it being most challenging in recovery services? So those are the questions. That's the task. We have groups pre-assigned. So we'll automatically put you in a group. If you're out in the waiting room for just a minute, be patient. Mana will get you into a group. And each group has about 8 or 9 folks in it. So that's the perfect size. There will also be a countdown ticker. It'll give you a 1-minute warning when you're coming back out of those groups into the large group. Are there any questions before we enter into this part of the meeting? Mana, do you see any questions in the chat?
No, I don't.
Okay, terrific. All right, so let's go ahead and go into our breakout groups. I'll see you when we're back together.
Drew, do you hear me?
I meant to hit unmute and I brought myself back here.
I did the same thing.
I'm so mad. I wanted to talk. Oops.
Crystal, there's an elephant behind you.
Oh, no. I meant to unmute myself. Sorry, guys, and I kicked myself out.
Joe, were we done? I'm sorry, I left the room. The room made me leave. So
We're in the
You're
big
good?
room now.
yeah, you're good. And I
We're in
can
the
back
big
you
room.
up. I can back you up on anything you need.
Sure.
All right.
Hey, everyone. Everyone should be joining shortly. So thanks for your patience.
Joe, this is really bothering me. I need to know your background. Is that one of the fake backgrounds, or is that your house?
Unfortunately, it's a fake background. It's the jungle room in Graceland. And by the way, Elvis had a birthday on Friday, so.
Welcome back to large group. In our group, I know we were kind of in the middle of conversation and then we got kind of yanked out of our conversation midway. So I apologize to our group, and we'll ask for their backup during our report out and make sure that we've captured everything. Hopefully you had a good chance to discuss everybody's experiences, their perspectives, what folks count as a value in using harm reduction strategies and recovery. It's only natural that kind of the challenges associated with that too come up in the conversation. So do you guys see my slide? I want to make sure that I've got that I'm sharing here. Pardon me. So Mana, you cue me when we've got everybody back in large group, okay?
Sure. One moment. We should all be here. Yep. We're all back.
Okay, so let's go ahead and I'm just going to call on each group and I beg your pardon, probably don't know our group numbers, but I'm going to call out the facilitator name and we'll report out that way. Just as a reminder, if you didn't assign or discuss who's reporting out, we've asked the facilitator to do that. Lindy, we're going to start out with you. I hope that's okay.
That's fine because I've, handed the ball off to John, who was our co-facilitator and took all the notes. And
there you go.
The team decided
More than
he
happy
would
to
be
share,
best
yeah.
to represent us.
And we did have a good group discussion. So for the first question, the experience really ranged from no direct experience, but feeling that it's part of the culture in the work environment to things such as MAT programs, both from the provider and the patient perspective. So incorporating those sort of experiences in the mindset of reducing the overall harm. I think that pretty much covered the bulk of our experiences.
How about the values that you saw?
So values, a lot of values, starting with the reduction in illness and infection from a public health standpoint. And then also the ability of harm reduction to address more of an incremental perspective in terms of a pathway to recovery, meaning what is it going to take to stay alive today, and getting people engaged in a process. It's a tool to reach certain people that maybe coaches or RCOs weren't reaching in the past. So really just a great way to get the mentality of recovery out and engaged with people in the community. And to piggyback on that too, it's just a different way to connect for some people. And I think we'll kind of go into that in the third question, because I think questions 2 and 3 sort of tied together, at least, for our group discussion. So I guess the way that it connects is, right, most challenging for you would be people of a certain generation maybe were very much exposed to the war on drugs and the Just Say No campaign. So having that social conditioning might be a challenge for some to sort of break with that mold of thinking that's sort of been implanted on them just by virtue of growing up when they did. So really shifting that focus away from abstinence based, not away from abstinence based, but allowing for the possibility of other pathways. Another challenge would be stigma, and specifically when people are trying to explain how it works to others who might be closed-minded or not willing to engage in some of the practices. And then obviously COVID related. I mean, obviously just being able to connect with people, that ability has been somewhat taken away because of COVID. So in the midst of a pandemic, it's kind of hard to advocate for certain things. So that's a challenge. And then our biggest challenge was probably legality, I think, was a big theme for us, especially when it comes to parenting and children, and how even though advocating for a harm reduction pathway could still expose the participant and their family members to potential harm. So that was a challenge that was discussed in our group. And then I want to open it up to anybody else in our group to see if I missed anything, but those were the notes that I took. So hopefully we addressed every question.
I would just add that in the value that the first and most important one that was mentioned, I think, was just keeping people alive, recognizing that you cannot help people find recovery if they're no longer living. And that's always a first step. I'm getting my internet connection is unstable, so I may be coming and going here. The other point I did want to make is in the most challenging, we had some participants whose primary job is to work with employers and help them to hire people in recovery. And that's one of the groups that John mentioned. It's so hard explaining harm reduction to employers. And that was a real challenge. And then the other group that some of the legality came out of were people who work primarily with families and focus on children in families with parental substance use. And that's where the legality really jumped out. And also the concern that even though people may be reducing their harm, they still may be exposing their children to harm. So that was a challenging piece of looking at this.
Excellent.
Did we cover it, group?
Yes, absolutely. Great job.
Terrific. Excellent. And Cheryl, I'll go to your group next.
So we had a great group discussion too. We were group number 2, and what I would like to do is introduce Joy, who ended up being our note taker and reporter outer. So.
Hi, everyone. So, you know, it's gonna sound a bit repetitive. You know, we're all hitting the same points, but the first one, you know, their experience ranged from working with on a daily basis to you know, when they first heard about this, being against it, to open-mindedness, and seeing progression over the years from abstinence to harm reduction, and just trying to grow and move with that. The second question, the value is seeing evidence to see the evidence of helping people just make it another day and seeking long-term recovery, and the cost saving and the health benefits, reducing mental stress and physical health concerns. And for the last question, seems most challenging was community understanding, reducing stigma, expanding on community collaboration with like law enforcement and other agencies, limited access in certain parts of the state. There's a lot of rural parts and, you know, distances in between major cities and little towns, and just needing more education all around. And how did I do, group?
You did great. I think that one of the points that came up for a few people was, you know, people with strong 12-step backgrounds not quite understanding what harm reduction is and how to help people. But through those different various educational opportunities some of us have had, it has helped to be open-minded and to learn that this is an opportunity for recovery community centers, but how to implement that at times is a challenge. So we're really looking forward to hearing the other 7 groups. So did we miss anything? Anybody else in my group want to jump in? All right, moving on.
Next, we will move to Jessica Parnell.
Thank you. So we were group 3, and I have to say that I have a tremendous group, and we definitely didn't have enough time to get through everything, I think. We spent a lot of the time focused on number 1. And so our experience with harm reduction strategies, first anywhere from, you know, currently engaging as a volunteer at an SSP. Others heard about harm reduction in the recovery coach trainings, also the peer assisted recovery training. Some first heard of it in active use. Some first are engaged in harm reduction through prevention. It's about getting the environment to encourage more services and to get more healthy, both physically and mentally. We also talked about engaging in harm reduction strategies through having loved ones in active use. And I was also really excited because we had someone in our group who once engaged as a participant of SANA and is now in the COP with us, which for me was a huge win. And I was very excited to hear that. For number 2, the values that we saw in using harm reduction strategies in recovery. We talked about there being no, you can't put a value on someone's life. So human life is, you know, one of the biggest values, the return of investment. We talked about building bridges that otherwise would be broken down. One person mentioned that their son is alive because of harm reduction. You know, we're meeting people where they're at and building that trust. And then some of the aspects of harm reduction in recovery that we felt were most challenging for us. We talked about educating physicians. We talked about gaining their trust being a challenge. We also kind of briefly, very briefly talked about maintaining personal recovery while engaging with people in active use on a regular basis. That was about it. Priscilla or any of my other group members want to chime in? Did I miss anything? Yep. So I guess that's it.
Okay, terrific. Thank you.
I think our screen froze.
Mary Ellen, if you can hear us, you're frozen.
I think we could move on. I'm just going to take over for Mary Ellen while she gets back on. So could we move to Joe and Polly's group?
Hi. Okay. So I don't know what number our group was, but here we are. You know, we had a pretty good. Whoop, some screen just went. We had a pretty good group with experience in harm reduction. You know, there was myself with my background. We had a lot of people in the recovery groups or other peer groups. Sorry, who want to get peer harm reduction strategies more incorporated into their groups. We did have someone who was against naloxone and syringe exchange way back in 25 years ago, and this person went to a conference and actually heard Edith Springer, who I don't know if he knows is considered the goddess of harm reduction, one of the biggest proponents of it in the United States back in 1997, and it changed the way that he felt about syringe exchange, because there was a pilot program that was authorized about 20 years ago in New Hampshire to set up a syringe exchange locally, and it never happened. And that was around 2000, 2001. We didn't get the law changed till 2017 to allow it. There's a lot of, we had several people that were either used harm reduction strategies in their own recovery or active use, and a few didn't even know it, myself included, like I talked about earlier. One of the biggest things that people talked about was, and we've already heard, you can't recover if you're dead. People think it's enabling. We talked about how if it is, if someone can't get into recovery, it doesn't help if they're dead or sick. That's another thing. We didn't really talk much about if they're sick, but we don't think about once people do recover, if they have HIV, hepatitis C, there are things that they have to live with in recovery. So harm reduction can actually make your life better, whether you're actively using or not. Some of the biggest barriers were and most challenging things were where everyone else said was community buy-in. I think that's everyone's big concern, but I also think that it's not just the mayors and the towns that have a problem, but it's also sometimes the people that are in the recovery business. We heard people talk about having to ship people out of the state for opioid use 20 some years ago, because we didn't do that in New Hampshire. We just did alcohol recovery here. That's actually, it's changed a lot over the years, but it's interesting that that's the experience we had here. So they didn't even know that it was a thing. Like we don't do that here. Now we do. Getting community buy-in is also something that I think we all talked about how to work on. We do have some ways that we can help with that from the Harm Reduction Coalition that I mentioned. So if people have a need or would like to learn about how to get more local buy-in, or just give talks to recovery organizations or other providers, if we can't do it, there's certainly other people in this audience that are also willing to help and do training for harm reduction. So that's pretty much it. Did I miss anything, Polly? Probably.
No, Joe, I think you got it. I think you covered. How about our group? Anybody else think, did we miss anything? Everyone?
No, I think you covered it all.
If not, other people did too. So yeah, thanks, Joe.
Thanks, everyone.
Not sure if Mary Ellen is able to.
I'm here, but I'm going in and out, folks. So I apologize for that. having some connectivity issues. I'll pull up the slides in a minute. But if the next group would be Ryan and Lori. So if you guys could go ahead and report out.
Well, you want to go? You took notes. And I can sign in afterwards.
I'm sorry, Ryan, did you want, did you, I didn't, you didn't come through.
Oh, I just said, do you want to start with the notes that you were taking, or should I run with it?
I think you could run with it and I can chime in if you miss anything.
All right, so we had our group, for our experience with harm reduction, more so went personal. We had a member of our group share about losing a loved one to an overdose who was, alone behind a closed door, and highlighted the importance of not using alone and open and honest conversations. And, hindsight's 2020, and it looks like we lost about 80,000 Americans to overdose for 2020. That's like 80,000 policy failures. So we've got to really be doing better. And same things the other groups are talking about, preventing death and disease, keeping people alive. But what really was interesting about our conversation is that it kept kind of steering towards conversational harm reduction, where we had some members of our group who can't really practice harm reduction, like needle exchange stuff in their day-to-day life. But, we kind of talked about how there's, harm reduction, capital H, capital R, there's like the policy advocacy stuff, there's harm reduction, like the provision of services, and then there's like conversational harm reduction, where we're treating people with compassion and dignity and respect. And if we take the harm reduction principles, we can really enhance prevention. We can intervene earlier in someone's experimentation with drug use by having open and honest conversations based in fact, educating people. And we talked about education, and that's like foundational to harm reduction. But really there was some barriers for agency policy, working with families, it seemed. And then the barriers for sure is that, we treat these health issues like a crime, and we're not going to have a public health framework as long as we're operating under prohibition. And prohibition doesn't work, and we know it doesn't work, but here we are. So, the challenges is that, the criminalization and stigma, and, stigma is just a nice way to talk about discrimination and oppression. Stigma kills people because of how we, view people. And, I'm happy to open it up to other members of the group if they want to share a little bit more about what we talked about. But it was a really great discussion.
Terrific. Any other comments from the group? Okay, let's go on to, is it Lena? Lena and Alyssa?
Hi. Our group shared a really similar items that the other groups have shared, but one of the things that we did talk about that was, I haven't heard that it was mentioned, was how treatment centers, MAT programs, like recovery housing, are not set up to practice harm reduction strategies. So for example, treatment centers or MAT programs will have contracts for you to sign where if you use, you have these negative consequences. And so how that's not aligned with harm reduction practices. Our group was really great. We had all different experience levels. We had someone say that this is the first time they've heard about harm reduction, to people that have practiced it in their work life and as well as in their personal life. One of the things that one of our group members said that kind of resonated with me was they had a family member that was experiencing substance use disorder, and if he had needle exchange programs, that family member might not be fighting the disease they're fighting today. And so that really resonated with me as well. We saw a lot of value. I mean, like Lindy said, the biggest thing is that you can't help someone find their pathway of recovery if they're dead and they're not breathing. But we talked about how it gives people dignity and respect. We talked about how person-centered self-driven, strength-based programs, people do the best in, because they drive it themselves, and they make their own goals, and how that's really important with harm reduction. We also talked about, someone had said it's human nature. People need to walk before they can run. And I really love those like really simple analogies. And also that harm reduction gives people more time and more options. And so that's really a huge value of harm reduction. Some of the things that were challenging, we talked about stigma, as a lot of other groups talked about stigma, and how it's a waste of valuable time, and it's a waste of a moment that you could reach somebody if you're always preaching abstinence, and that's not their pathway, how that's not going to work. And so when you have that opportunity to spread a message of recovery, you're missing that opportunity if you're not talking about harm reduction. Yeah, so I think that's what my group talked about. I don't think I missed anything, but if any of my group members would like to say something before we move on to the next. Nope. Okay, thanks, group.
Claps. Terrific. How about Donna and Jeff?
Hi. So for question one, we had people who work in the field and then people who have experienced harm reduction. And one person had said that they've seen it work both ways, and kind of analyzed why it works for some and not for others, and found that the people who had support or stable housing and their primary needs were met were more likely to succeed than somebody who didn't have that available to them. For question two, which is the value, it keeps people alive, prevents spread of disease, reduce cost to health care systems, gives people an option to reduce in place of a gateway to start with a new path. That needle exchange is the first line of communication for someone to move forward in harm reduction. And then the third question, the challenging was the stigma and uneducated doctors, public perception that having an understanding of harm reduction can, or not having an understanding of harm reduction can cause more harms in some cases. So if I missed anything, anybody from group 8, feel free to add to it.
Any additions from group 8? Okay. All right. So I'm actually doing the report out for our last group. So I'm going to call on Rob and others and folks to please chime in. It was an exceptional group. We actually ran out of time, and I'll do my best to capture our key points. But the personal experience with harm reduction really ranged from folks that are in recovery right now, from just 10 months sober to long-term recovery. So a lot of personal experience. Professionally, a lot of experience in delivering training and actually working with folks in trauma. We've got lots of folks that have the CRSW and really working in harm reduction right now and as a main strategy to their recovery. Some of the values have already been said. A lot of them have already been articulated. But one of the things that came up that I think was pretty powerful is one of the values is that you really need to love the person until they can love themselves. But obviously the respect and just the love and welcoming the person into recovery without any judgment really helps that person's recovery in their pathway. And then some of the challenges that were mentioned is how do you know when you're using in moderation, if that's part of a harm reduction or balancing that with, is it an excuse to just use? So one person commented that that was sort of a challenge in her work with folks using the harm reduction approach. Stigma is most certainly a challenge. Substitutes for crystal meth. More than half the people in recovery one person was working with don't have a substitute for that. And no needle exchange program in the area. So I'm going to ask my team, anybody else have thoughts on any of these, the experience, value, and challenges that you want to bring out and talk about? No?
I think you hit them all.
Excellent.
Yeah,
Terrific.
you did pretty
Great job.
good.
Thank you, group. Okay, I've gone off video camera just to make my internet stable. So I apologize that I'm just kind of a talking black square right now. So thank you, everybody. I see that there has been some chatter in the chat box, lots of resources. I see Joe has shared some resources, and Ryan has shared resources. We will make sure that we save these and post them to our website. But at this point, we're going to start to wrap up, and I'll share some resources, and we'll do the evaluation here in a minute. But before I go full speed ahead, I want to just ask Cheryl or Polly, do you have any thoughts or any kind of closing comments that you wanted to say?
So I just want to say, thank you. It was like an amazing, amazing group. Thanks for all the panelists and presenters who have such, a broad knowledge on this topic. And I know it always helps me to keep hearing about it. So, and the fact that we had 73 people come to our community of practice is just awesome, that our message is getting out there and people want to hear about it. The other thing I want to say is we are going to put a SurveyMonkey link up here, and you will need to complete that SurveyMonkey link about what you thought about the training to get CEUs that you can apply to the LADAC board if you need them. That's the only way you'll get a certificate of attendance for this. So I encourage you to do the survey that just went into the chat also. But and it also will help us in our development and our next community of practices that we'll be having. And maybe someone who's a little more prepared knows the date of the next one that we're having, maybe in March or something. So I would just want to thank you all, and remember to fill out the survey so we can get you some CEUs. Thanks.
Yes, the link is up, and I'll share it again in our PowerPoint as well. Here's some resources, and there's actually more in the chat that we'll make sure gets up onto our website. It's the New Hampshire Harm Reduction Coalition, the National Harm Reduction Coalition, lots and lots of practical resources on both of these sites. And if you want to just understand, if you're kind of one of those folks that just knows a little bit about harm reduction, this is all a new conversation for you. We encourage you to go ahead and explore those harm reduction principles and just really delve into the information of, meeting people where they're at.
And there was something else. Your website is nhtac.org, and you'll see a little box for community of practice, very easy to navigate their site. So just want to make sure. Oh, there it is right on the screen. Look at you.
So yes, yes. And if you haven't seen us yet, please do visit us. This is a brand new website that's just up and going. Like I mentioned earlier, we are the New Hampshire Technical Assistance Center. We are new, so I've really enjoyed meeting all of you today. But please do visit our site, and there you can download copies of the materials from this meeting. You can learn about other communities of practice and visit, we update it on a regular basis, so visit us often. You can also request technical assistance on our site. We're providing technical assistance services to folks across prevention, treatment, and recovery. So our services are available to you. And you can also register for upcoming COP meetings and events. If this is your first COP meeting, I strongly encourage you to sign up as a member of this group, and you can do that again right on our website. Polly, I think you covered the CEU credits. And again, make sure you fill out that evaluation. Upcoming meetings. So you can mark your calendars now. March 10th is the next Peer Recovery Support Services COP meeting, and that will be focused on trauma-informed practice. And then again on May 12th, that community of practice will focus on parenting and family issues and recovery. That's the plan right now, to focus in these areas. So we hope you can join us at those meetings. And finally, if you have not seen the link in the chat, here it is right here. We encourage you to take this evaluation. Your feedback really is important to us, especially as we get these COP meetings going again. We're really excited and thrilled to be able to work in collaboration with the Bureau and Harbor Care and organizing these meetings for you. So we'd love to hear your feedback. And I'll also do an extra plug. Another way to give us feedback on our website is we actually have a little link at the bottom of our website when you visit there. And if you're going to our website to look for a specific resource and you don't see it, you can let us know what it is that you want to see, and we will tailor and make our website useful for you. So that's all I have, folks. And that concludes our meeting. Thank you, panelists, jumping in, doing a stellar job. And thank you, everybody, for your active participation today.
Thanks, everyone.
Thank you. Bye-bye.